Sandeep Senior has very eloquently pointed out as to how to analyze a growth disturbance due to a facial bar and how to excise the facial bar. And my brief is to talk about situations where bar excision is not an option or bar excision is not possible or it has failed. So let's see exactly which are these situations where a bar excision is not possible. So as Sandeep also pointed out in his talk, whenever a bar size is greater than 30% of the cross-sectional surface area of the physis, a bar excision would not yield results. It would not help in restoring the growth. And in these cases, a bar excision is not possible. Apart from that, if the growth remaining is less than 2 years or if the child is already past skeletal maturity, bar excision is not an option. Then we can have situations where we have growth disturbances and facial injuries, but there is no clear-cut bar formation. As you can see in this X-ray, that there is a completely disorganized and starred physis, but there is no clear-cut facial bar. In these cases, there is no question of performing a bar excision. Apart from that, as Sandeep clearly pointed out, that bars which are secondary to irradiation or infection, they have a poor prognosis with bar excision. So once we have identified these situations, we have to identify as to what are the clinical problems that growth disturbance is creating. So the clinical problems that can occur secondary to a growth disturbance are, number one, you can have angular deformities, as in this child with severe skeletal dysplasia. Secondly, you can have shortening of the bone, which would give rise to limb-length discrepancy. Thirdly, you can have tenting of the epiphysis with distortion of the articular surface, as seen in this case, or you can have combinations of these. So once you have analyzed as to what is the clinical problem that the facial injury is producing, you should also be aware about the natural history of this problem. In other words, you should be aware as to what problems can occur in the future. So to help with this, we have to consider the age of the child. So we obviously know that if a growth disturbance occurs in a younger child, the effects are going to be far more severe and far more serious than in a growth disturbance occurring in an older child. Secondly, what is the anatomical location of the facial injury? So for example, a facial injury which occurs in the upper limb, for example, in the proximal humerus, will produce lesser severe effects than a facial injury in the lower limb. Thirdly, is the facial injury occurring in the growing end of the bone? For example, if we consider the femur, since the proximal end of the femur contributes only 30% to the increase in length of the bone, proximal femur growth arrest would create lesser effects than a distal femur growth. Once we have analyzed all this, that we know that these are the problems at hand and these are the problems which are likely to occur in the future, we have to consider as to what are the weapons in our armamentarium for solving these problems. So the various solutions can be, if there is though there is a facial injury, there is the facial architecture is still sufficiently well preserved, we can do what is the growth modulation procedure. So as you can see in this case, there is a facial disturbance, there is a growth disturbance at the distal end of the femur, and there is a metaphyseal defect. But the facial architecture is reasonably well preserved, and therefore in this case a growth modulation was done, and as you can see, it helped in correcting the deformity. Then if the physis is severely damaged, as you can see in this case, then in this case then we have no option but to perform a corrective osteotomy. Like so the deformity has been corrected with over here. Thirdly, if you have a limb length discrepancy, then you would need to perform a limb length equalization. So in this case, lengthening of the bone has been performed. The other option for doing a limb length equalization would be doing epiphysiodesis of the contralateral side. Or if there is an incomplete growth arrest, as you can see in this case. So in this case, you would need to do a completion of the epiphysiodesis, which is done by.
Yeah.
So if you have an incomplete facial arrest, then you can treat this by completion of the epiphysiodesis, like in this case of the distal radius, where there is only a facial partial growth arrest, and you can do a completion of the growth arrest of the epiphysiodesis of the distal radius as well as the ulna. So let's take up a few examples. So this was a child who presented in the neonatal age group with septic arthritis of the knee and osteomyelitis of the distal femur. As you can see, there is a physeal injury to the distal femur. And indeed, over a period of just 18 months, she had a crotus genu-valgum deformity. As you can see from this, from the imaging, there is a gross disorganization of the physis and a gross scarring of the physis, but there is no clear-cut physeal bar formation in this case. So in this case, we went ahead. The problems that we faced in this case was a progressive deformity. Obviously, there is going to be a further recurrence because the child is still very young and there is a limb length discrepancy. So in the first stage, we did an osteotomy and combined it with an 8-plate growth modulation. And this over a period of time gave correction of the deformity. However, the limb length discrepancy still persisted, for which in the second stage, a lengthening was done. And this is the current status. So the child is now, we have been treating her since the neonatal age group and she is now about 8 years old. But we know that we are in for a long haul. There is still the second growth spurt, which is still to come. And therefore, we need to keep this child. We are aware and the family is aware that long-term follow-up is necessary. Another example. So here, this is a child at skeletal maturity who has presented with growth arrest of the distal tibia. And there is a distal tibial varus and a limb length discrepancy. Since there are two problems which are to be solved in the same sitting, we decided to do correction by means of an external ring fixator. Here we used the ortho-SU fixator, and this resulted in correction of the deformity as well as the limb length discrepancy. So to conclude, every case of growth arrest is different. In each case, we have to identify the problem at hand and we have to predict what problems can arise in the future. And we have to plan the treatment strategy accordingly. It is not just a treatment that you have to do now, but also what interventions you may need to do in the future. Thank you so much.